Halo traction. So I just wanted to briefly mention the things that we need to be looking for in our patient in halo traction. So number one are the cranial nerve palsy. And the most common one is the six, which is abducens, and this causes eye movement difficulty and results in double vision. So whenever you're seeing the patient, whenever you're making rounds on the patient, when you're doing your nursing checks, you would ask the patient if they see double looking to the side. And oftentimes the patient will not realize they're having the problem. So you need to ask the patient about that. And when that happens, then you take off the traction and see what happens. So,
why is this nerve commonly involved?
It is because it can be affected by the muscles that are impinged on by the pens themselves, and so the traction actually can cause traction to the nerve. So that's the reason. So and this cranial nerve affects the ability of the eye to go to the outside. So if it's paralyzed, then your eyes go in, and when you look to the side, you have trouble looking to the side. So that is the reason for the comment. So the other cranial nerves are much less likely, but cranial nerve 7, which is facial nerve, and frankly, and then the trigeminal, which is cranial nerve 5. But these trigeminal. But these are rare, so I don't worry about that. The one that is part of our check is this one. It's the abduction. That's the first one and most common one. And then the other thing to ask about is weakness. So this is spinal cord. So, and it usually starts with the lower extremities. So this would be, you ask the question, do your legs feel weak or do your arms feel weak? And then also you look for changes, changes in gait. And so the other, I mean, obviously anything can happen, but these are the common things. These are the things that we should be asking every day when we talk to the patient. The danger signs are new double vision.
New double vision.
Any weakness.
Any weakness.
And change in walking, standing, or sitting. Yeah, it's interesting. It's really rare, but we should. And then sensory changes. Numbness or tingling. And then in terms of physical exam changes, we should be always checking the lower extremity reflexes.
What is tinny? What is tinny?
So it would be
针刺麻木针刺，
new hyperreflexia, and or obviously, or clonus or Babinski, but just mainly it's just having an idea of what her baseline is and then checking the reflexes, on a daily basis. In terms of general neurologic status, like if there was a problem with the pins, then we need to think about, and they always have a headache when they start. So the first 2 days they have a headache, but then it should go away. New headache, nausea, or vomiting. That could be from pressure from the pens or penetration of the pen or something in the central nervous system. And the reaction, if you find something like this, is you release the traction first, and then you call the doctor. Okay? Yeah. So the reaction is release the traction, and then check with me. Okay, it's okay to make that decision on your own if you find any of these symptoms. So, and again, the most common early neurologic signal is that double vision from the abducens nerve. So you ask this question: are you seeing double when you look to the side? So that's what you ask the patient.